Thanks. Very excited to be here. I wasn't familiar with HARC or home visiting before this, and so when I was reading about it, I thought this is exciting. There's a lot of, I think, overlap between the interests in precision home visiting and precision medicine and the behavioral sciences and biomedical applications. Okay, and so the goal, I thought, my personal goal was to try to get to know some of you and maybe find some partnerships. Okay, all right, hang on. Is that better? Yes. Okay, great. I'll try not to look too uncomfortable. And so I thought I would just say a little bit about my background, which will hopefully serve kind of a dual purpose of getting me some leeway for not knowing this literature or this area very well, and also maybe spark some ideas for how we might work together. So I'll just have 2 slides on that, and then I'll talk about treatment regimes in precision medicine in biomedical applications primarily, and then a trial design called a sequential multiple assignment randomized trial that I think may be of use. Okay, so I run kind of a diverse group at NC State, and we work on a variety of different decision problems. So some of those are in precision medicine, which we'll talk about, but we also work in outreach and for middle and high school students, and we have 6 designers in the lab, and so we go around and do art exhibits that are at the intersection of art and science, and so I'm very interested in STEM outreach in particular, and the sort of vision for the group is practical but statistically rigorous methodology for estimation, inference, and decision making. And so while we're really methodologists, most of our methodology is really rooted in application. And in terms of the major sort of research thrusts in the group, we work in precision medicine, spatial temporal decision problems, including things like wildlife management and control of infectious diseases. And then we also work in more technical things like inference for non-smooth functionals, which I won't talk about, but that sort of underpins these things. And then how do we improve K through undergrad STEM outreach? And in particular, we're interested in rural areas in the Southeast because I'm from North Carolina, or that's where I am now. And then in terms of the kind of topics we think about, we work in causal inference, Markov decision processes, machine learning, computing, dimension reduction, games, both in the sense of video games and games for fun, but also in the mathematical sense of adversarial decision problems. So in human trafficking, it's people in the intelligence community and law enforcement against people who are trafficking either in other persons or in drugs or guns and so on. And then disease modeling and local asymptotics. We work with a lot of different groups, and so I put this up just to emphasize that these applications, even though a lot of them have been in biomedical, some of them have been in like food safety and defense and intelligence and information propagation and geolocation and so on. And so really we're just excited about difficult and interesting decision problems. And so this seems like a new and exciting area that I would like to learn more about. Okay, so treatment regimes in precision medicine. I think a lot of people have heard this saying at the top there, the right treatment for the right patient at the right time, or the right treatment for the right patient at the right dose at the right time, and so on. And it's widely recognized that the best care requires tailoring to individual patient characteristics. And clinicians have been doing that for a very long time. Right? You develop rapport with the clinician and they make treatment recommendations accordingly. And I saw this in the precision home visiting. From a statistical point of view, we're interested in doing this in an evidence-based way or a data-driven way. And the goal is to improve patient outcomes, but also by giving treatment only if and when it's needed, you can reduce cost and so on, and treatment burden. So the factors that might be considered, well, from a statistical point of view, the things we like to focus on are demographic information, physiological information, medical history, genetic and genomic factors, environmental factors, and so on. But there's more to think about when we're looking at a treatment decision, including patient individual preference, local availability, cost, and so on. And so there's some real non-statistical problems here that I think require careful consideration about how do we really decide what the right treatment is when there's multiple outcomes and patients have very different preferences across those outcomes and different needs. So if we kind of have this oversimplified view of clinical decision making, we think, well, they take all the available information, they somehow synthesize it, they combine that with their own judgment and experience. Maybe there are treatment guidelines in a given context, and they make a recommendation. And then that gets mathematized in precision medicine as a sequence of functions or maps that take as input what you know at the time and give as output a recommended treatment. And the goal here is to inform but not dictate decision making. So a lot of this has to do with communication of information. Okay, so mathematically, we talk about estimating rules or recipes or algorithms for treatment recommendation that might say this family would maybe benefit from this type of model of home care, but that's not really what we want. We want to provide information about what different kinds of treatments, what kind of outcomes they might lead to. And then having said that, I'll go and mathematize this as a rule. So the way that we formalize this is a sequence of functions or rules, and they take as input everything you know at the time, and they give as output a recommended treatment. And the stages here could be fixed in time. They could be every few months or so, or they could be driven by events. So you give somebody a treatment, and it stops working, and then you have to change treatment. Okay, so they don't have to be fixed in calendar time. They can be outcome driven. And we define a regime, a sequence of rules, as optimal if it leads to the maximal mean utility if you were to apply it to the population of interest. And we can talk about whether or not a mean utility is appropriate relative to maybe a percentile. Pushing up sort of the lower end is another goal, and so on, but I'll focus on the mean just for simplicity. Okay, so here's an example. This is an example of a treatment regime in the context of post-traumatic stress disorder in cancer patients. This is a mobile health intervention, so it's delivered over a smartphone. And it has two stages. In the first stage, it asks, does the patient have a distress score that's over 3? If so, give them something called the Cancer Distress Coach, or the CDC. Otherwise, if their post-traumatic stress disorder symptom score is greater than 20, I won't get into the science of these measures. They're just things that we can measure. If it's over 20, then also give them CDC, otherwise usual care. So if you look at this, you immediately see more severe symptoms, you get CDC, otherwise usual care. And at the second stage, if you're a responder, so if you respond to your first stage treatment, then you don't change anything. So it seems to be working. Otherwise, if you were using CDC initially, and you had a PTSD symptom change more than 3, then you add mobile coaching, or M-coaching. Else, if you started on CDC and your distress score is now greater than 4, you add FaceTime cognitive behavioral therapy, otherwise FaceTime CBT only. Okay, so the idea here is that this is supposed to improve patient outcomes, and you can see how it's being tailored to their baseline characteristics and then also the responder status and so on. But the other hope is that we can look at this and we can ask scientific questions like, does it make sense to give CDC to people who have higher severity or not? Okay, so that's this sort of communication or hypothesis generation piece. Okay, so we don't really want to estimate black box rules for prescribing treatment. We want to generate new hypotheses that we can test. Okay, so what are the ingredients? Well, you have the decision points. And again, those could be fixed in time, or they could vary according to the health trajectory of a patient. And so these are just opportunities to change treatment. And we have to talk about what characteristics we're going to measure. Okay, so that's some summary of their up-to-date history. And it also should include things like personal preference, which is considerably harder to measure. And then what treatment options are available. These can depend on history. So for example, in schizophrenia, if you have a movement disorder, then certain kinds of antipsychotics should not be given to you. If you already have hypertension, then something that causes severe weight gain should be taken off the table, and so on. So those are more medically driven, but there's also things about what kind of burden it places on you because of the lifestyle you lead. So if you live in rural North Carolina, asking you to drive into Durham, for example, every time you need treatment is a huge burden. If somebody lives in Durham, it may not be. So okay, so we need to think about those options and how they depend on patient characteristics. Okay, in terms of data sources, we can talk about observational studies like Framingham and EHR data, or randomized clinical trials. And among those, the one I want to talk about that may be unfamiliar is a sequential multiple assignment randomized trial, or a SMART trial. Just as a bit of funny trivia, my advisor was the sort of person who coined this term, but they called them SMAR trials for a long time. And they were at a meeting at the Methodology Center. That's when one of our speakers is from there. Somebody said, hey, if you put trial in the end, it becomes SMART, which sounds a lot better than SMAR. So now there's SMARTs instead of SMARs. Okay, so let's talk about those. So SMARTs, these are a randomized design that the design is specifically intended to evaluate treatment sequences. Okay, so when you're talking about a scenario where treatment might be changed over time, we want to be able to efficiently evaluate sequences. And the basic idea is anytime you have a treatment decision to make where you don't know what to do, there's not good evidence about which treatment is best, you randomize. And the original motivation was to think about causal issues associated with longitudinal treatment. And almost as a thought experiment, if you have observational data, you could ask, what's the ideal data? What would have been if we had been randomizing treatment all along? And then eventually people realize, well, we should just do that. And this allows you to efficiently compare both partial and full treatment sequences, meaning you can ask questions like, what's the best first treatment, or what's the best last treatment? If maybe you can categorize them as something like switch or augment or intensify. You can ask, is it better to do one of those things across all first stage treatments and so on. And we can also estimate optimal treatment regimes like the one we saw. And another thing is to better mimic clinical practice. So if in clinical practice you give somebody a treatment and if it doesn't work you give them something else, then that's how our trial should look. So in cancer they were doing this long before anyone had used the term SMART, where you would give somebody initial treatment and then the non-responders would get a salvage treatment and the responders would get a maintenance. Okay, so here's an example of a SMART. This is the one that corresponds to the PTSD example I showed. So this is the design. The red R's are randomization. So initially patients are randomized to receive, I don't know if this may not show up. Okay, that's too sensitive for me. Okay, they're initially randomized to either treatment A or treatment B. It's just the distress coach or standard care. Then they're assessed for response. And if they're responding, then you can see that you follow the yes arm and they just continue whatever they started on. And if they didn't respond, they get re-randomized. So in the distress coach arm, they get either mobile coaching or FaceTime CBT. And in the standard care arm, they get either the CDC plus mobile coaching or FaceTime CBT. And I hope I'm still on the mic when I turn around. I'm trying not to completely turn my back to you. So here response status is at 4 weeks. The response criterion is PTSD symptoms and whether or not they exceed a threshold, and the primary outcome is PTSD symptoms. So I'm going to go through a few of these examples, and I'm going to try to point out some points of confusion. So one thing people will get confused about is whether or not the response criteria, the thing used here in the response box, has to match the thing you care about at the end. And this is an example where they do match. In a lot of cases they do, but they don't have to match. Okay? So here's another example. This is school-age children with ADHD. They're initially randomized to behavioral modification therapy or medication. And they are assessed every month for response. If they respond, they just keep getting what they were getting, and if not, they get re-randomized. And here you can see the BMOD arm gets randomized to either medication or to intensified behavior modification therapy. And the medication arm, they either augment with a behavior modification therapy or they intensify their meds. And here, response is assessed every month, and it was teacher-reported classroom performance. But in terms of the outcomes they cared about, these included things like parent-teacher reported outcomes, academic assessments that occurred at the end of the year, and rule violations and so on. So you couldn't use those endpoints as a surrogate if you're taking exams at the end of the year, for example, right? You can't have those in the middle, so you can only use surrogates, and that's fine. Here's another example. This is a Zika trial on the Dominican Republic. So initially they're randomized either passive messaging, so this is a mobile health intervention, so passive messaging on the mobile device plus insecticide and condoms, or insecticide plus condoms only. And I put this example up because this is a public health type SMART. And here the goal is to identify which patients need the expensive treatment and which ones will get by in the less expensive treatment. So the active control is sort of the less expensive treatment, and then you have this messaging. And then you assess responder status. The responders continue. Non-responders get either active messaging or in-home visiting. And in-home visiting is very expensive, right? You're sending somebody out to make sure that they're, in this case, engaging in protective behavior. So they're wearing insect repellent, they're covering water sources, they're having protected sex, and so on. And so the idea is you only want to assign that if you really need to, because there's a lot of human capital involved in that. Okay, thanks. So here the response status. So these are pregnant women, if that wasn't clear. Sorry. So pregnant women. So they're assessed for response at their first trimester visit, where the response criteria is their compliance. And the thing you care about is whether or not there's an infection, which you can't assess until full term. So this is a setting where it's impossible to use the same response criteria and final outcome. Okay, so SMARTs are a gold standard for estimation and inference in treatment regimes. The sort of canonical reference is Murphy in Statistics in Medicine, 2005. So they're highly flexible, and there's many, many different designs. I tried to show 3 pretty different ones. And they can address a wide range of clinical questions, but even though you have this flexibility, a lot of times the choices are dictated by the science. So which treatments should be considered at the first line? Often people have a good idea what that is. What kind of response criteria? Well, that should match what you would do in practice when you decide this isn't working, what criteria you're looking at. And another way to sort of think about these trials, if you identify the best treatment for each patient, you can turn that around and say which treatments are being assigned, or sorry, which patients are being assigned to treatment A, which patients are being assigned to treatment B, and that gives you subgroup identification. So you can ask what types of patients are we recommending each of these treatments to, and can we look at those characteristics and learn something about why these treatments are working for these groups. Also, estimation and inference. One thing I don't want to dwell on, but I feel like I should mention, is that there are some complicated inferential procedures involved with these trials and their analyses, and so some standard procedures don't work, like the bootstrap or normal approximation, but there's a lot of good software now for analyzing data from these trials, designing these trials, sizing these trials, and so on. And so there's a very mature kind of literature on the methodology for these trials. And so I think I will just stop there. Thanks.